Uh, g- Good afternoon, everybody. Today, my topic is current management of severe burn. I'll emphasize myself on management and pathophysiology only. So, first of all, the causes that I won't go in detail, the different etiology, electrical, chemical, and radiation exposures. And these are the sub means of primary and secondary survey, that is the depth, that first degree, second degree, third degree burns, depending upon the uh, different layers of the tissue structures involved. The first degree superficial, that is the epidermis, and second degree also part involves the part of dermis and subcutaneous fat. Third degree, and when it is including your muscles as well as bone, then it's the fourth degree. So before going to detail of the management, let us be sure that how these patients differ from the normal shock or the septic shock. So first of all, we have to understand the pathophysiology. Vascular permeability and edema is there, altered hemodynamics, hypermetabolism because of stress, and increased gut mucosal permeability, decreased renal blood flow, and immunosuppressants. These all contribute in. So hypermetabolic stress, that is because of stress, catecholamines and cortisols are released, and along with glucagon, so it causes the gluconeogenesis and peripheral lipolysis and proteolysis. So, burn shock pathophysiology, as we already know that the combination of distributive and hypovolemic shock, there is an impairment of the myocardial contractility because of the release of TNF, tissue necrotizing factor alpha, and the availability of calcium ions at the tissue level or the cellular level. Increased capillary permeability, and other contributing factor is the oncotic and hydrostatic pressure imbalance, causing the outpouring of the fluids, electrolyte, and proteins, and most of it happens in the initial first 24 hours. As far as the management is concerned, we will discuss in the following heads, like ABC of burn. So, as like other emergencies, it needs to be, the airway needs to be protected in certain scenarios, like the suspected inhalation burns, hypoxemic and swollen oropharynx, sign of the respiratory distress. And obviously, because the patient may be having some that need assuredly may be required because of breathing. The chest expansion is not permissible because of the increase in the resistances because of that. So third is circulation, that is the fluid resuscitation. Fluid losses must be replaced, and because to prevent the shock and the multi-organ dysfunctions. When the burn is more than 15%, total burn surface area in adults, and in children more than 10. Good vascular access should be taken, and non-burn tissue, it should be a large bore cannula. Fluid monitoring, urine output, CVP, and arterial line should be the part of the fluid resuscitation, and maximum fluid losses occur in 24 hours. So, as per the Parkland formula being the most consensus formula, 4 ml per kg per percentage of the burn. 50% of it we replace in the first 8 hours, and the rest of the 50% is replaced in remaining 16 hours. So, as a part of the primary and secondary survey, assessment extent of the burn, I won't go in detail with it. These are the assessment of the burn depth. The clinical assessment remains the gold standard. Other methods that like biopsy and histology can be considered, laser Doppler techniques, assessment, perfusion, and video microscopic. Accuracy is there, but disadvantage is that the skin contact can cause the infection. Wound management, the rapid removal of the devitalized tissue and earlier wound closure is the main strategy. Treat the wound infection without topical antibiotics agent. The wound becomes colonized with the gram-positive organism within 48 hours. And beta hemolytics, streptococcus and staphylococcus are the predominant one. The gram-negative organism appears after 3rd to 21st day, like Pseudomonas, Proteus, and Acinetobacter baumannii are the most common organism. A SHAR will become infected unless it is removed and the re-epithelialization process or the surgical excision is mandatory. Wound management, systemic antibiotics should be given only when the systemic infection is there, and it should be guided by the uh, labs, the culture reports, showing the better than the bath and less wound cross contamination. Dressing must be done under sterile conditions. And blister removal is controversial. Recommendations are that you should aspirate the fluid and keep the skin intact. Otherwise, it will breach the further infection. Wounds are useful for diagnostic, but they cannot differentiate between the colonization and true infections. Other being the procalcitonin, C-reactive protein, white cell count, neutrophils, temperature remains the useful marker for monitoring of sepsis. Delayed burns associated with increased infections. Deep burns. Wound management, superficial burn heal earlier, and large deep burns takes 2 to 3 weeks time. Wound management, moist wound healing. So the healing wounds should be kept moist. Increase activity and the growth factor. Increase activity, surface proteolytic enzymes, improved oxygen and nutrient delivery. So wound management, early excision or grafting is associated with the better results. These are the how we take the graft and close. It should be done as early as possible. Tropical and antibacterial agent should be used, that is the sulfadazine, povidone, meperonate, and chlorhexidines, mefenate, acrylflavin. The acrylflavin is the good antiseptic, but it can cytotoxic, irritate the skin, and staining can occur. As far as the ICU management is concerned, basically we have to concentrate on the fluid resuscitation, inhalation injury, prevent the preventable complications like compartmental syndrome, and additional therapies, infection, inflammation, sepsis are the primary concern. So fluid resuscitation remains the cornerstone of the modern critical care, directly improves the survival, and maintaining the tissue perfusion is the ultimate goal. If we delay the resuscitation by 2 hours, it increases mortality. American Burn Association practice guidelines do not recommend the use of fresh frozen plasma without any active bleed. No advantage of colloids over the crystalloids, so crystalloids remains the choice. Factors influencing the fluid resuscitation are the total burn surface area and burn depth, inhalational type of burn, age, delayed resuscitation, and need of hysterectomy, and use of alcohol or other drugs. So this is the plant's formula by which we give the fluid like 4 ml, as we have already discussed. The initial half is given in the first hour, and rest remaining half is given in the next 16 hours. This is the management at the specialized center, non-specialized centers, where first of all, primary and secondary assess, then prepare the wound, and after that cover wound as early as possible, and later the post-wound care that leads the pain management and offers the psychological support if may be required. So airway, that is the compromise. First of all, assess the airway. Again, the same, it is a protocol based. The compromise or the risk is compromised. If it's compromised, you have to protect the airway. Breathing, if it is compromised, then there's to mechanical and carboxyhemoglobin smoke inhalation should be taken into the consideration. Then the circulation, so if it is compromised, perfusion to the extremities. Then next is neurological disabilities, impaired score on the Glasgow Covers scale. If it is that again we have to consider hypoxemia and hypovolemia, and fluid resuscitation as early as possible. The exposure, the fully Now, fully expose the area, depth, and full assessment, primary and secondary survey, and fluid resuscitation as per the Parkland's formula. So endpoint of the resuscitation, none of the, no one in the factor is fully justified that urine output, heart rate, and mean arterial pressures, lactate trends shown some better, if we are following the trends, we have shown the good results for the endpoints. And inhalation energy, marked increase in mortality, morbidity, increase in fluid requirement, acute airway obstruction. So obviously in these patients, the early protection of the airway. Carboxyhemoglobin, strong indicator if it is more than 10%, urgent need of endotracheal intubation and mechanical ventilation. And again, the prophylactic antibiotic have no role until unless it is proved that there is some culture or report is favoring. Preventable complications like hypothermia, compartmental syndrome, deep vein thrombosis, heparin-induced thrombocytopenia, neutropenia, stress ulcers, adrenal insufficiency, seen in some cases that as high as 36%. Abdominal compartmental syndrome, that when the pressure, abdominal pressure is more than 20 with at least one organ dysfunction, like renal, gut ischemia, cardiopulmonary malfunctioning, and need of regular monitoring of the IP. Appropriate volume, intravascular volume should be maintained. Sedation, analgesia, paralysis, and ascertain may be required. Initially, we should opt for the minimally invasive abdominal decompression. If it fails, then we should consider laparotomy, because laparotomy itself carries the mortality of 88 to 100% cases. Additional therapies like pain management, enteral nutrition should be started as early as possible, and high protein nutrition should be started. Strict glycemic control is one, and anabolic steroids have been recommended, some studies, and wound management, as we have already discussed. The infective and inflammation sepsis, total leukocyte count is a poor indicator. Baseline temperature reset is 38.5 degrees. So, and it remains altogether for months together. So it's not a good indicator of the sepsis. Other clues can be thrombocytopenia, worsening of mental status, renal, and the pulmonary status. Any infection, until proved otherwise, should be considered as a catheter-related breastfeeding infection. And prophylactic antibiotics do not have any role until unless it is proved that it is infectious. So take-home message is that fluid resuscitation is the cornerstone of the burn critical care. Inhalation burn require more fluid than calculated. The inhalational burns. Over-resuscitation leads to complications. Better endpoint resuscitation is high priority. Future improvement in the burn management includes the rapid surgical debridement, dynamic range of the fluid type, and of course the team approach. Pain management and enteral nutrition as early as possible, and the high protein diets. Thank you.